Good afternoon, everyone. Welcome to the Continuous Professional Development uh, session conducted by Sri Lanka College of Specialist Family Physicians. As today is a special day because we are having a midday session today. And before we start, there are a few housekeeping rules. Please make name similar to that in the participation center. Towards the end of the lecture, a link will be shared in the chat box. Please fill out the provided form. Note that attending the session for a minimum of 45 minutes and completing this are necessary. You can take the true answers check boxes. The correct answers for the post test and the certificate will be sent to you via email. Please keep your microphones muted throughout the session. If you have any questions, kindly type them in the chat box. They will be addressed later. With that, I would like to introduce today's resource person. He's Dr. Prageeth Premadasa, Consultant Venereologist from DG. He has BS from University of Colombo and completed his MD in the PGIM, and he's a fellow in European Committee of Sexual Medicine. And in a person, he's one of my relatives. And so I know how dedicated he is towards his work. So with that, I invite Dr. Prageeth Premadasa. Sir, platform is all yours.
Thank you very much for the kind introduction, Sopun. Hope you all can hear me, isn't it?
Yes, we can hear you.
Okay.
Yes, we can.
All right. Okay. So we'll talk about sex today. So it's basically emphasizing on sexual health matters which are really important in primary care. I mean, as family physicians, as primary care doctors who manage patients, and usually the people who manage patients in the first time sometimes for the patient. So it's really important to know about sexual health matters when we really deal with patients, when we care for patients, because I will let you know how important is addressing these issues in your care. So basically before let me just all right. So before I take you through the slides, let me just brief you the segments that I'm going to cover during this talk. So first of all, I will be talking about human sexuality and sexual response cycles of men and women, which is really important in understanding these theory segments if you really need to understand the sexual dysfunctions. And also we'll be talking about the types of male and female sexual dysfunctions, assessment and management options that we have for those sexual problems. So it's really difficult to go into a detailed analysis within the short duration of time, but I will try to give you some idea about many issues that we have to know. But at the end, as Supun suggested, we can have a Q&A session or discussion just to clarify what you have in your minds. So basically, if we talk about sexuality, if we really need to understand sexuality is more than just the word sex. So it's a complex term. It's complex because it's comprised of many things, like sexual attitudes, feelings, and beliefs of a person, gender identity. If you don't know what's the meaning of gender identity, I will explain it later in the slides. The sexual behaviors of a person, capacity for erotic response, sexual orientation, and that also I will explain later. and attraction. So sexuality of a person is comprised of these segments. So that's why it is really difficult to explain sexuality in one word. And also it is influenced by many factors like media, religious beliefs, sometimes for children, parents. So like many factors usually affects one's sexuality. So if I further explain you the segments, we all know we have a biological sex, the sex organ that we usually have from birth can be male, can be female. Sometimes rarely we get ambiguous genitalia. And gender identity is what we have in our brain. So in other words, gender identity is our mental sex. So sometimes people are born as biological males, but they have a female gender identity or mental sex. So discrepancies. So that we need to understand. Attraction is our sexual orientation, that is to whom we are sexually or romantically attracted. So again, this segment is also important. And also gender expression that we need to understand. This is what, how we are seen by the society or the others. Gender expression is that. So as you can clearly see here, you can have many combinations in the population, when it comes to the gender identity, orientation, biological sex, expressions like that. You can have many combinations, right? So if you can just identify or understand the diversity of these segments, I think that's enough for the time. Right? And as I mentioned, now when you talk about the gender identity, that is your mental sex or what you have in your brain, right? So you can see there are many individuals in a society, sometimes their biological sex is compatible with their gender identity. Then there's usually, they don't have many issues, but sometimes there's a discrepancy in between their biological sex and their mental sex, right? So you have seen people, we call them transgenders, right? So sometimes they are born with biological male sex organs, but they think as females, and later they really need to change their biological sex according to their gender identity, because gender identity is really powerful. And when they, I mean, they always think that they are, I mean, if they have a female gender identity, they always think that they are females, even though they have a biological male sex organs. So that thought is powerful, which can sometimes lead to depression, suicidal ideation, and things like that. So that's why, I mean, even the ministry has understand these issues, and there's a process for those kind of people to change their biological sex and to change their identity to the level that they need, right? So there's a legal process, and always I'm telling this because if you encounter this type of a person, always you can refer them to a place where transgender clinics are, and there's a legal process. And once he or she's been assessed by a psychiatrist, sexual health consultant, as well as an endocrinologist, they will enter to the pathway where they can change their sex. And they can, I mean, legally also they can change their birth certificate, and they can have a new identity card, right? But no one should be, I mean, should be suffering from these kind of issues. We call it dysphoria, gender dysphoria. So it's quite normal to have any combination of these gender identities, as I mentioned before. So it's quite normal to have them. Sometimes parents, they bring their children when they, I mean, notice this kind of a discrepancy in them. But unfortunately, we can't change their attitudes, sexual orientations, or gender identities by force or by any medication. All what we can do is we can refer them to services where they can be served well. So when it comes to sexual orientation, also same scenario. You can see in the left hand extreme, you can see exclusively heterosexual people in a society, as well as in the other corner, you can have exclusively homosexual people. And in between, you can have bisexual people, and this bisexuality also, according to this Kinsey scale of sexual behavior, can vary. Sometimes, mainly they are homosexual, but sometimes opportunistically they show some heterosexual behavior. So like that, and again, when it comes to the society level, we can see many people like this. And when they enter to an environment where their behavior can be influenced, they can even change their sexual orientation with time. So sexual orientation always is, it's not a fixed one. With time, sometimes it can change. And also it is quite normal to have many sexual orientations in a society. However, it's really difficult to draw a line in between what is normal and what is abnormal when it comes to sex. As far as it's not harmful for the particular person or their partner or to the society, we actually don't comment on those sexual behaviors medically. But sometimes there are, as you know, there are paraphilias or abnormal sexual behaviors which can have legal issues like pedophilia and things like that. So that type of situations, as primary healthcare physicians, we really need to address and act promptly because it's sometimes harmful for the other party. So otherwise, usually, having a sexual behavior which is not harmful for the particular person or to the partner or to the society, we actually generally call them normal. And also it is really important, when you educate people also, you really need to emphasize that everyone should have a clear idea about their sexuality. If they really need to enjoy their sex life, they need to have a clear idea about their sexuality. So their gender identity has to be very clear. Their orientation has to be very clear. And if they have fantasies, desires, they should have a clear idea about them. And then only that person can enjoy their sex life. And also it is really important, we need to accept that in a society, there can be many variations in these sexualities. And we actually don't medically, we don't consider them as psychological or psychiatric problems unless it's been diagnosed by a psychiatrist, or we don't call them as mental health problems, right? So unless the particular person is under depression or under distress due to this particular issue, right? So everyone has to be has to have a clear idea about their sexuality, as well as no one should be under distress because of their sexuality, right? So that's the simple theory. So if someone is under distress because of his or her sexuality, he or she need medical advice or sometimes treatment, because sometimes these issues can lead to depression, anxiety, and sometimes to suicidal ideation. So if we go to the definition of sexual health, it's similar to the WHO definition of health. It's not merely the absence of disease. It's the actually it's the ability of a person or a couple to have pleasurable sex without any coercion, discrimination, or violence. So that's the simple definition of sexual health. So let's move on to male and female sexual dysfunctions. So before that, actually, we had an idea about the sexuality, and also when we talk about male and female sexual responses, also we really need to have an idea about the male and female sexual responses if we really need to understand about the male and female sexual dysfunctions. So you all know there are many differences between men and women. So if you have read this book, Men Are From Mars, Women Are From Venus, you know how the opposite sex think, right? So probably most of you all have seen. If you have not, please read these books. If you if you really need to survive with the opposite sex, it will give you some valuable clues, right? So if we just talk about a man's sexual response cycle first, it's very straightforward. So as you can see, it's like an on and off switch, can be easily switched on with a visual stimulation like this. So man's sexual response cycle is usually initiated with visual cues, and it's very simple. So that's why, I mean, I'm just presenting this classic example. So whenever a man sees a woman or a female, he tends to look at the female, right? Now, this is a classic example. Now, this husband has got the most beautiful wife in the world, but still he looks at the other women. So it's the normal sexual response cycle of a man. So they are more reactive to visual cues. Sorry. Right. So that's the main thing that we need to understand. And so if the man's sexual response cycle is this, how will be the woman's? So it's like this. It's very complicated. And there are many switches, many equalizers, many tuners. So a lot of things. So interestingly, now in men, it's just a visual cue. But for women, some are actually not related to sex. Now, what are these things? It's really important to understand these tuners or the cues, because if you really need to understand the woman's sexuality, you need to understand what triggering factors which can lead to their problems, especially when we are talking about sexual dysfunction of women. Like now, cuddling with the partner, sometimes having her own time with daily chores or the work of kids, sometimes gifts, shopping, money and credit card. So these are not related to sex, but they can be used or utilized as sexual stimuli, actually, to ignite the sexual response of a woman. So it's quite different. So it's like this. All right. I don't need to comment on that. So basically, compared to men, women are less likely to become spontaneously sexually aroused. They need some external stimulation, especially from the partner. And their sexual desire is much more reactive to their surrounding circumstances. Now, we see sometimes couples, they have problems, sexual dysfunctions. When we explore the problem, what they tell is they have sometimes a privacy issue. Sometimes it's very simple. Sometimes the door lock is not in order. So that's the main reason for their sexual dysfunction. And sometimes the daily work or their stress, I mean, the work-related stress. So that type of environment factors usually affect the women's sexual response very much when you compare it with the men. So it's basically women actually need a reason to have a sex, but men usually just need a place. It's pretty simple. So the sexual response cycle of a man is a very simple cycle, which was best explained by two people, two scientists called Masters and Johnsons. And it's a linear model which comprised of actually 4 steps. The excitement, and then they come to a plateau, and they have their orgasm, and then they go to a resolution till they have another excitement. So this is the response cycle of a man, which was actually described by Masters and Johnson. But when it comes to women, it's not like that. As you can see, see it's complicated. I don't want you to go through all the details here, but you can see many external factors also can affect the women's sexual response, which was actually explained by a person called Bassons. And also, if you carefully look at the previous Masters and Johnson's linear model for men, the ultimate objective or ultimate goal of a man's sexual response cycle is the orgasm. But when it comes to women, it's not the orgasm. Orgasm is a bonus. The ultimate goal of a women's sexual response cycle is the emotional intimacy that they acquire during during the sexual relationship or the intercourse. So that's the main difference. And there are many external factors can affect their sexual response cycle. It's really important to understand these issues if you really need to understand the male and female sexual problems or dysfunctions. So if we put these phases of sexual response cycle of a man, so we can easily place them. We can place the sexual dysfunctions in the phases. Like in the excitement phase, they can have erectile dysfunction, low desire, libido problem, and in the plateau also they can have erection problems. And when it comes to orgasm, they can have premature ejaculation or mainly retarded or delayed ejaculation. But since the women's sexual response cycle is complicated, it's really difficult to place them on the response cycle of a woman. So basically, internationally, there are 3 categories of female sexual dysfunctions. Vaginal pain or penetrative disorders. Earlier, it was called vaginismus. Now, we don't call it vaginismus anymore. Hyperactive desire or arousal disorders, or in simple terms, low libido, and orgasmic dysfunctions. So these are the 3 categories of female sexual dysfunctions that we see. Right. So let's talk about the epidemiology a little bit to understand the gravity of this problem. Unfortunately, we don't have any researchers in Sri Lanka, how do you call population studies to assess the prevalence or the incidence of sexual dysfunction. But if you go through the international data that we have, a very large study, which is also known as MMA studies, actually carried out among 1,800 men who were, the age group was 40 to 70, and 52% were having some kind of erection problem. And a younger age group was again studied in 1992, actually 18 to 59 year age group. Again, 10% had ED. And overall prevalence of premature ejaculation is 25 to 40% in a population, in any population. So this same thing applies to Sri Lanka also, especially with the rise of non-communicable diseases like diabetes. We see a lot of sexual dysfunctions. Right, when it comes to female sexual dysfunctions also, if you can see, 32% were complaining lack of interest in sex or low sexual desire. So like that, female sexual dysfunctions are also not uncommon, but sometimes they are underreported in countries like ours because of the cultural barriers and sometimes lack of education. They don't present to the services. So I think when you know that there could be a problem as primary healthcare physicians, you all should refer and identify their problems. Unless you ask from them, they don't usually come out with their problem. And also this is, actually you don't need any research to, prove the impact of sexual dysfunction to the quality of life of a person. So as sexually active people, adults, you know how it can affect the quality of life of a person. But here, not like other diseases, it affects the index patient as well as it affects the partner. Sometimes, now, if you carefully go through the details of this study, it shows now it has, the problem has affected 69% of men, but more than that, the women or the partners have been identified the erectile dysfunction as a problem. So sometimes more than the index person, the partners are affected. Okay, let's move on to the assessment, because once we identify there's a problem, we need to assess. Now, sex is like your Ferrari or your car. It should move forward without any problem, right? Because it's a biological function. If it is not moving forward well, then we need to assess why it is not moving, right? So in the assessment, therefore, for the purpose of description, we can categorize the causes into 4 segments. You can have biological segments, you can have psychological causes, you can have cultural and religious issues, unlike in other health problems. And also, you need to assess the relationship also, because without a good relationship, you can't talk about good sex life. So let's talk about biological factors. So basically, as you know, many medical problems, right? Sometimes maybe the age, hormonal problems like lack of estrogen, lack of testosterone, natural causes like menopause, non-communicable diseases like diabetes. Now, in a study actually carried out in Sri Lanka, found out that 70% of diabetic men were having sexual dysfunctions. So it's a huge amount. Right? So neurological problems like multiple sclerosis, thyroid issues, and especially iatrogenic sexual dysfunction, that is really important, because there are many medications, many surgical procedures or medical procedures which can lead to sexual problems. Malignancies and sometimes treatment for malignancies can lead to sexual problems. So we need to get a good history to find out the root cause of the problem or the biological problem or the biological factors. Because when it comes to the management of sexual dysfunctions, if you really need to manage it, managing is not giving symptomatic relief. If you really need to manage it well, you need to identify the root cause of the problem. So that is why you need to have a good assessment. So that's about biological factors. Talking about the biological factors further. If you take erectile dysfunction, I will just give you some statistical information again. just to emphasize the gravity of the problem. So approximately 40% of men are affected at the age of 40, and nearly 75% of men are affected at the age of 70. So it's a huge problem. So everybody likes to have an erection like this, but unfortunately, it's like playing pool with the rope for many individuals after 40 especially. So the assessment of this biological, the biological assessment, the importance of this biological assessment is because if you take erectile dysfunction, especially the vasculogenic erectile dysfunction, we consider it as an early warning sign for cardiac disease. Now, I just wanted to highlight that because it's really important to detect these people with sexual dysfunctions, because maybe an early warning sign to an upcoming cardiovascular problem. So here is the explanation. As you can see the you can compare the diameters of penile artery and coronary artery. And when the atherosclerosis is under operation, what happens is it blocks the small arteries first. And you can see clearly the penile artery is the smallest compared to coronary, carotid, and femoral arteries. So that's why the vasculogenic erectile dysfunction usually appears 3 years before a major coronary event. So it's really important to understand or identify, detect them, investigate, and give proper medication to prevent the upcoming cardiovascular event. Right. So that's why, again, it's really important if someone presents with a sexual dysfunction, we need to, especially erectile dysfunction, we need to assess them. We need to assess their cardiac health also. So cardiology assessment is mandatory because sometimes can be linked with many cardiac events, especially ischemic heart disease. Right. So the next segment, we're talking about this. So if I ask you the question, what is your main sex organ? Answer is here. You can see it's not the organ in between your legs. It's the organ in between your ears. Your brain is your main sex organ. So that is why, if we talk about the evolution, when men, the human, when they have a bigger brain, they have more sexual problems, right? So sexual problems, sometimes when they think too much, they can have sexual dysfunctions. And if they don't think about their sexual behaviors much, they can have sexually transmitted infections. So it's like that, right? So talking about the psychological causes for sexual dysfunctions, as you all know, sexual dysfunction sometimes can lead to psychological problems. And sometimes psychological problems can lead to sexual dysfunctions. There's a two-way connection in between these issues. So depression, anxiety, poor body image, sexual abuse in the past, alcohol and recreational drugs, stress, sexual orientation and gender issues. So as I mentioned before, when someone is having an orientation or gender issues or gender dysphoria or any psychological issues related to homosexuality or bisexuality, they can have sexual problems. And as I mentioned before, we need to assess the person's relationship also, because without a good relationship, we can't talk about a good sexual health. So always we need to ask about the partner's sexual problem. The classic example is vaginismus or difficulty in penetration. So what happens is when the woman can't engage in sexual activities because of the pain and the contraction of the muscles, ultimately what happens to the male partner is he develops erectile dysfunction. So always it's really important to assess the partner also. And there are relationship issues. If there's a good relationship, we actually see less sexual problems among couples. But sometimes conflicts and violence can lead to many sexual health issues. Lack of intimacy, lack of privacy also can affect. I mean, I don't need to explain by common sense, you know, how privacy matters when it comes to a sexual health of a person. Cultural issues, cultural and religious actually, restrictive sexual morale, especially with some of the religious beliefs. Lack of sexual education, again, is another problem in Sri Lanka because of the lack of education, sometimes they don't know they have a sexual problem. The classic example is dyspareunia. So a lot of women think that dyspareunia is normal. Right? So they bear the pain and they try to avoid sexual interactions, but they try to survive. So it's like that. And also cultural suppression of the women. And again, it's common in this part of the world. So when it comes to the management, so that is the assessment. As I mentioned before, the importance of assessment is you need to have a clear idea about the root cause of the problem and also what are the precipitating as well as what are the maintaining factors of the current problem. So you need to understand everything if you really need to manage it completely or if you really need to give a comprehensive care for the patient. So as management options, we have medical, physical, surgical, and psychosexual intervention. And usually what is successful is a combination of all these, especially medical, physical, and psychosexual interventions. And it's been scientifically proven also. So if we talk about the medical management of sexual dysfunctions, there are many options for male and female sexual dysfunctions. If we start from PDE5 inhibitors given for erectile dysfunctions, there are many medications that can be used effectively in managing male and female sexual dysfunctions. So these are some of the options that we can use, which are usually called conservative treatment modalities. It's just give some conservative treatment. And for females also, a lot of people don't know about the medications being used for female sexual dysfunctions, but there are many medications that can be used for females as well. So physical methods used in the management of sexual dysfunction, the classic example is the vacuum constriction device used for erectile dysfunction. I have shown you a picture. You can read these. I mean, if you really need to get the details, you can read on the internet about how to use this and how effective is this. And this is usually we use for the management of erectile dysfunction, right, when other methods and other medical methods fail. And another physical method that we use for erectile dysfunction is shockwave treatment. It's very popular and it's available in Sri Lanka also. And apart from these methods for erectile dysfunction, PRP injection is becoming popular now, especially when they have vasculogenic erectile dysfunction and poor flow to the penis. Shockwave treatment and P-shot or PRP injections are really effective. And for female sexual dysfunctions, physical methods can be used, especially in conditions like vaginismus. So we do gradual dilatation of the vagina using vaginal trainers. And also pelvic floor physiotherapy. pelvic floor is really important when it comes to the sexual function of a person, because ejaculatory problems in men and sometimes conditions like vaginismus are linked with pelvic floor problems, right? So pelvis is an organ which is actually it's an emotional organ which usually responds to your emotions. So that's why when you are scared, when people are scared about sex and sometimes for the pain, they develop some involuntary contractions, which is also known as vaginismus. So pelvic floor physiotherapy and rehabilitation is important. Again, we can add them. I mean, so as an adjuvant therapy can be combined with other methods like medications and physical therapy. So failing everything, conditions like erectile dysfunctions, interventions like surgical interventions can be done. So here is an example how a penile implant is being placed. And so this is an inflatable penile implant, which is available in Sri Lanka also. So as the ultimate option, where other treatment methods are failed, we can use surgical methods for the management of dysfunctions like this. Sex therapy or psychosexual interventions also can be used, as I mentioned before. So with medical and physical treatment, if you can combine these interventions, it will be really useful. So providing sex education or making them to understand the problem is called sex education, right? So it's basically can resolve like 50% of the problem. Apart from that, techniques like cognitive behavioral therapy, when they have doubts, when they have wrong ideation in their heads, and also techniques like mindfulness, techniques like sensate focus can be used in psychosexual interventions. So a lot of people actually ask, how do you give sex therapy? There's no clear-cut answer for that, because it's, I mean, giving sex therapy is not like cooking something. So it's it's not a cookbook, right? We always need to tailor-made whatever the intervention for the couple or for the individual, right? Sometimes combination of these techniques being used. So that particular therapy is usually designed for that particular problem and for that particular individual. And there's no like preset treatment plans or therapy for any individuals to be used. So providing sexual health services, it's actually a challenge, because now you may be a good physician who manage a lot of medical problems, and maybe you help them to overcome many difficult situations in their health. But what actually we need to consider is the ultimate happiness of the person, right? When it comes to the ultimate happiness of the person, so sexual health always matters, right? So if you can address that part also in your comprehensive management, they'll be really grateful to you. Now, especially, I will tell you what are the instances that you need to be careful, and how you can contribute towards these issues. Now, we learned that many medical problems and many medications can lead to sexual problems. Now, medical problems like diabetes, as I mentioned before, like more than 70% of diabetic patients are having some kind of sexual dysfunction. But if you don't ask them whether they have a sexual dysfunction or not, they don't come out with their sexual problems, especially in a busy clinic where people are being seen like it's really busy and there's no privacy to express their sexual issues, even though they have become a burning issue for them. Especially patients taking beta blockers, SSRIs. Usually we don't ask them whether you have a sexual problem or not. But knowing that they are closely linked with sexual problems, especially for young people, if you can just ask them, they'll be really grateful, because if you ask them, if you manage them, or if you refer them, they'll be really delighted. And I have seen many examples. The doctors who have identified the sexual problems and referred patients, they were really happy about the primary healthcare doctor. Right. The patients who undergo surgeries like prostate, patients who receive radiotherapy, I think more than 90% of the patients develop some kind of sexual dysfunction. And natural causes like menopause. So if you are seeing a menopause person just after the menopause, just ask about their sex life, how is it now, and if there's a problem, always try to help them. So in managing, and when addressing the health, the sexual health problems, you need to have a good empathy. And also, since they are very intimate issues, you need to maintain the privacy and the confidentiality as well. So in other countries, there are like sections where they consider sexual rehabilitation. Now, after a road traffic accident, even after a pelvic fracture, after a surgery, after receiving cancer treatment, they do consider in the follow-up how they are doing with their sex life. All these options are for people, and for, they are actually prescribed equipments after some issue to re-establish their sex life. The first line, the first picture you can see. So this was actually usually prescribed for pelvic fracture patients. So like that, I can explain you many equipments being used. So like that, there's no system in Sri Lanka actually to address these issues. I think as family physicians or primary healthcare doctors, if you can just have an idea about these options, or if you can rehabilitate them, if there's a need, they'll be, as I mentioned before, they'll be really grateful to you. Right. So just to highlight the importance of asking the sexual issues of patients, from patients. Now, this is a study actually carried out. If I tell you, I have highlighted the important statistics. The majority of patients actually prefer active inquiry about sexual health concerns from primary healthcare physicians. Right? Because they usually don't come out with their problems, especially when it comes to sexual health matters. Even abroad, they don't come out. I don't need to explain the situation in a country like Sri Lanka, where a lot of cultural barriers are there. So I think we need to think twice. And if we have an idea about the contributory or the precipitating factors which can lead to sexual dysfunctions, if you can be sensitive more, and we can ask about their sexual problems, and we can help them to overcome those problems, which will really actually improve their quality of life. So it's basically a teamwork. Usually they don't directly come for sexual health centers located island-wide. Usually they visit their primary healthcare doctor, and then if they refer only, they come to the healthcare services or sexual health care services. So in summary, now what I wanted to highlight was male and female sexual dysfunctions are really common. It's not a rare entity. Sexual problems are not only affect the quality of life of the index person, but also their partners, right? Proper assessment is important for a long-term management and to look for associated conditions. Like I actually brought you a classic example of coronary artery disease, but there are many conditions that I can explain you as associated conditions for sexual dysfunction. Whenever relevant, you need to ask for sexual problems and refer, because what we really, what is important really is at the end, the quality of life of a person. And sometimes with frustrating living conditions, having sex may be the only pleasure for a layman. So please identify and refer, manage them. So again and again, I'm telling you, they'll be really grateful for you. Right. Okay, I think that's it. If you have any questions, I'm more than happy to answer them.
Thank you so much, sir, for that very interesting and informative session. And just for the information, the book you showed, Why Men Are From Mars and Women Are From
Yes.
Venus, is available in Sinhala also.
Yes,
As,
yes. It's available
the
in Zoom.
translation is Ganu Pirimingen Venaswarne. I think it was translated by Leelananda Gamachi.
Yes, that's
And we have two questions in the chat
okay.
already.
Okay.
One is, sir, can balanitis cause erectile dysfunction?
Okay, now there's no direct relationship in between balanitis and erectile dysfunction. But the problem is, as you know, when there's balanitis, sometimes it can be very painful. Especially the burning sensation, which is associated with certain kinds of balanitis, is unbearable. In that type of situation, definitely the patient will develop some problems with their erection because of the pain, because they can't concentrate on the erection or they can't concentrate on the pleasure because the pain is prominent. Otherwise, there's no direct relationship in between balanitis and erectile dysfunction. The other thing is, if someone is having balanitis, especially the candida balanitis, we need to think about what is diabetes. So diabetes is sometimes is the first presentation of, candida balanitis is the first presentation of diabetes. So as you know, diabetes is closely associated with erectile dysfunction. And sometimes because of that also, balanitis patients are having really high chance of developing candida balanitis patients are really high chance of developing erectile dysfunction. There's no direct relationship, but indirectly there can be links.
Thank you, sir. The second question is, can masturbation cause sexual dysfunction?
Okay, now it's a famous question usually asked by many people, many individuals in many forums. Now, when you talk about masturbation, medically, we don't take it as a harmful thing. We consider it as a safe way of having sexual pleasure. But only thing is, sometimes any pleasurable thing, can lead to addiction, especially when it is associated with issues like porn addiction or internet addiction. Now, what happens is addiction, I mean, masturbation related addiction usually has two arms. Psychologically, they can be addicted. Like their threshold or the stimulation that they need to have ejaculation usually sets on a higher position when they frequently watch porn. Because what happens is it's called sadonistic adaptation. Sadonistic adaptation is when you watch porn and when you masturbate, you have a very high level of pleasure. And usually it is less when you have sex in real life. So when you watch porn and masturbate, your threshold, I mean the stimulation level which is needed for orgasm sets in a higher position. So what happens is they don't get that pleasure when they have sex in real life, which can lead to erectile dysfunction, as well as especially they can develop delayed ejaculation because they can't reach that level of pleasure during real life sex. Right? So those are the problems with the adaptation, and psychologically also. So any addiction is a psychological problem. So they can have anxiety, depression, and things like a lot of psychological issues due to addiction. It may be to porn, maybe to my masturbation. So with that, they can have, I mean, as I mentioned before, many psychological issues can be linked with sexual dysfunctions. And by that also, they can have sexual dysfunctions in later life.
Thank you, sir. And another question is, do we have specific transgender clinics,
Yeah.
or else should we refer to the closest venereologist for further management?
Yes. Now, what we can do is actually there are two established transgender clinics in Sri Lanka. One is in NHSL, one is in Kandy, right? So the transgender clinics are usually led by the psychiatrist, right? So as you know, Dr. Kapila Singh and Dr. Pabasari Ginige are the two leading psychiatrists who are running these clinics, right? So what you can do is if you have a problem, I mean, you can even refer to a sexual health center where a venereologist is, or you can refer to the psychiatrist, right? So if they have a transgender clinic locally, they will manage the patient, or they will refer to the specific center where these issues are being managed.
Okay, sir. Are there any more questions? Up to now, there are no other questions in the chat.
Okay.
So I would like to thank Dr. Prageeth Premadasa, Consultant Venereologist, DGH Mathara, for giving his time during the lunch hour for us for this very informative and very interesting topic, which as primary care physicians, we must know. This is not something we nice to know. This is something we must know, because like you said, we encounter the patients first, and we should know to identify. We must know how to identify and how to refer. So thank you so much, sir. And the link is already in the chat box. Please fill the Google form. And if since there are no other questions, we'll wind up today's session. Thank you for your participation, and thank you, sir.
Thank you. Thank you so much.